Okay, welcome to this lecture, and we are talking about valvular heart diseases and cardiomyopathies, as you can see. So when we talk about valvular diseases, we basically mean those diseases that affect the valves. And when we talk about cardiomyopathies, we basically mean those conditions that affect the heart muscle itself. In other words, the myocardium. So as we talk about valvular heart diseases, you should be aware of the valves that are in the heart. And we talked about this earlier. But they are what we call the atrioventricular valves. These ones that you can see here. In other words, they are a link between the atria and the ventricles. So the tricuspid and the mitral valve are the atrioventricular valves. And then we also have what we refer to as semilunar valves. So the semilunar valves are these that basically lead away from the ventricles. And one of the examples here is the pulmonic valve and the aortic valve. So when we talk about valvular heart diseases, it basically means that the valves are not working very well. In other words, they are not doing or performing their function to the expected standard. And so valvular diseases can be either as a result of valvular stenosis, and by stenosis, we basically mean that the valves are unable to open efficiently, yeah, because of the reduced lumen or the hole through which blood has to pass, because of reasons or the other, as we can see, as we shall see. And then valvular insufficiency basically means that the valve is unable to close well, and as a result, it allows blood to regurgitate or blood to flow back. So these are the two causes of valvular diseases. So when we talk about the causes, it can be infection, whereby we have infective endocarditis, we have rheumatic heart disease, syphilis, especially in its tertiary stages, can bring about these conditions. Others can be hypertension, connective tissue diseases, and then cardiomyopathies. All these can bring about valvular heart diseases, as we shall see. So what changes occur to the valve leading to valvular heart diseases? One of the changes is that there is stretching or tearing to the chordae tendineae and the papillary muscles. Remember, the papillary muscles are those, and actually the chordae tendineae, that system, these are the structures that hold the valves in place, yeah, especially the ventricular valves, yeah. So when they are stretched, yeah, it basically, or when they are torn as a result of maybe an infection, then that basically means that the valves will not be able to perform as they are supposed to perform. So this can result from a heart attack, or what we refer to as a myocardial infarction. It can be as a result of infection of the heart valve, or even trauma, yeah. But we can also have what we refer to as a mitral valve prolapse, yeah, whereby we have leaflets flowing, uh, the leaflets basically flow back, yeah, into the left atria during the period of systole. It can also be fibrocalcification, yeah, whereby we have these valves are basically fibrosed, and they have a lot of calcium in them, yeah, and as a result, they end up narrowing, yeah. So this usually occurs in adults who are 65 years and above. So because of the too much deposition of calcium in the valves. Then also the dilation of the valve annulus. Basically, the valve annulus is that ring, yeah, that holds the leaflets or the valve cusps, yeah. So the annulus. So when it dilates or when it enlarges, that basically means that we shall have valvular insufficiency, yeah, and as a result, we shall have leaking out of the heart valves, yeah, leaking of the heart valves. We have what we call the normal valves. So, and within the normal valves, we usually have non-directional blood flow, whereby blood only flows in one direction. And so for normal valves, we have blood flowing in only one direction. And we've talked about these. We have the two atrioventricular valves and then the two semilunar valves. Yeah. Now, it is also very important for you to understand that for a valve to work competently, or for a valve to work well, it has to depend on the annulus, which is basically the ring that holds the leaflets. Yeah. Then we have the cords and then the papillary muscles. Yeah, the papillary muscles, these are the structures where the chordae tendineae are attached. Yeah, and then also ventricular wall layers. These ones also have to be well. In other words, for the valve to work effectively and efficiently. So what you can see is basically the valves, yeah. And so when we talk about the annulus is this circular structure on which the cusps attach, yeah. So again, as I said, the annulus is this circular structure on which the valve cusps attach, yeah. And then these structures, these distinct structures that you can see are what we refer to as the leaflets. So basically, valvular heart disease is defined according to the valve that is affected. So it's basically, it's not a general thing, but it depends on the valve that is affected, yeah? And it can either be stenosis or regurgitation. So with stenosis, we are saying that the valve does not open all the way, and therefore blood finds it hard to go through, yeah? And examples, we said some of the causes of this is calcification of the valve as a result of too much deposition of calcium. And then with regurgitation, we are saying that the valve does not close all the way. And as a result, blood leaks, yeah, blood leaks and flows back. Yeah, that is what we refer to as regurgitation. So we've talked about this stenosis. The orifice is smaller, impeding or interfering with the back with the forward flow of blood. Yeah, and with regurgitation, we have incomplete closure of the valve, which results into backward flow of blood. Yeah. So let's talk about the different. Remember, we said the definition depends on the is defined according to the valve or the valve which is affected. So let's straight away go to mitral stenosis. So when we talk about mitral stenosis, we basically mean that there is stenosis of the mitral valve. You know, the mitral valve is an atrioventricular valve, as we said. And so mitral stenosis is the most common valvular disorder, yeah? And it's usually caused or is brought about by rheumatic heart fever, as we talked about earlier. And it can also be caused by bacterial infection, thrombus formation, calcification, and this basically leads to obstruction of blood flow from the left atria into the left ventricle. What is the pathophysiology? So here the pathophysiology is that if we have narrowing, if we start here, you have narrowing of the mitral valve. What can that lead to? it can lead to two things. One, it can lead to increased left atrial pressure. Remember, if blood is not flowing down towards the ventricle, it basically means that it will accumulate, yeah, within the atria. And as a result, when blood accumulates, it leads to increased pressure, yeah, increased atrial pressure. And then because of the increased atrial pressure, then we have the increased pulmonary pressure. Remember, the blood that comes to the atria, to the left atria, is coming from the pulmonary system. In other words, it's coming from the lungs. So if blood is not flowing well, then we shall also have it being accumulating within the pulmonary trunk, and as a result will lead to congestion, and which will lead to either right-sided failure or a reduction in the exchange of carbon dioxide and oxygen. Yeah, but it can also lead to left atrial hypertrophy as a result of increased pressure. So the other arm, we have decreased blood flow to the left ventricle, and therefore leading to a reduction in cardiac output, and therefore we have left ventricular atrophy, and then fatigue. So these are the two arms that basically explain the pathophysiology of mitral valve stenosis. Now, what are the manifestations? In other words, what are the clinical signs and symptoms? You see things like exertional dyspnea, fatigue, palpitation. You have a loud heart sound, loud fast heart sound. Remember, heart sounds, we have S1 and S2. And S1 is basically closure of the atrioventricular valves, yeah? So if we have stenosis, then it basically means that the first heart sound, in other words, S1, will be very loud. Yeah. Then we also have a low-pitched diastolic murmur, hoarseness of voice, and this is as a result of the pulmonary congestion, and then hemoptysis, which is also still as a result of the pulmonary congestion that we have seen in the pathophysiology. And then we have chest pain, again, as a result of the too much congestion within the chest. And then we also have seizures or even stroke because of the decreased cardiac output, and as a result, blood does not go to the brain, and as a result, it can lead to seizures and a stroke. So those are the clinical manifestations of mitral valve stenosis. Now, with mitral valve regurgitation, we basically mean incomplete closure of the mitral valve. And here we see that rheumatic disease or rheumatic heart disease is also a predominant cause of the condition. Yeah, but it can also be as a result of a congenital abnormality, infection of the heart valve, what we refer to as infective endocarditis, rupture of the papillary muscles, yeah, following a myocardial infarction. Remember, the papillary muscles and the chordae tendineae, these are the structures that are supporting the mitral valve, yeah, and the tricuspid valve. So if they are destroyed, if they tear as a result of a myocardial infarction, that basically means that we shall have the, incompetence as far as the mitral valve is concerned, leading to what we refer to as mitral valve regurgitation. What are the causes? We have myocardial infarction, rheumatic heart disease, mitral valve prolapse, things like ischemic papillary muscle dysfunction, and then infective endocarditis, which we said is basically inflammation of the valves as a result of bacteria invasion. The clinical manifestations are manifested by fatigue and weakness due to decreased cardiac output, You have exertional dyspnea, you have, cough and pulmonary congestion. You have things like right-sided failure. Remember, blood is flowing back. Blood is gushing back. Yeah. Ideally, blood. Remember, we said for a normal valve to function, there should be unidirectional blood flow. But if you have the mitral valve is basically incompetent, if you have mitral valve regurgitation, it basically means that the left ventricle contracts to push blood, through the aortic valve, then it basically means some blood will flow back into the left atria. Yeah, what we refer to as mitral valve regurgitation, and then we shall have all these clinical manifestations. Mitral valve prolapse, we talked about this, and we said it's basically as a result of uh, a chordae tendineae and the papillary muscle destruction as a result of rupture due to myocardial infarction. But it can also be an inherited connective tissue disease or disorder, which can either leads to enlargement of one or both leaflets of the mitral valve. Palpitations, chest pain, dyspnea, these are some of the clinical manifestations of mitral valve regurgitation. We have been talking about mitral valve stenosis and regurgitation. And remember, we said that the definition of valvular heart disease depends on the valve that is affected. Yeah. So let's also talk about aortic valve stenosis. And with aortic valve stenosis, you know where the aortic valve is. It is a semilunar valve. Yeah. It basically leads away from the left ventricle. Yeah, into the aorta. So when it stenoses, it basically means it will not allow free flow of blood from the left ventricle to the rest of the body because it is stenosed. Yeah. And what are the causes? It might be as a result of rheumatic heart disease, atherosclerosis, or even congenital valvular diseases and malformations. Yeah. Now, what is the pathophysiology of all this? Yeah, we are going to talk about it in a minute, but we are saying that it can lead to left ventricular hypertrophy. Yeah. Remember, if it is stenosed, then we are going to see this in the pathophysiology actually. And so we are saying that when it is stenosed or when it narrows, yeah, we have two arms. Again, you can see left ventricular hypertrophy because of the too much pressure with which the left ventricle has to pump blood, across the narrow opening. So the left ventricle ends up hypertrophying, yeah? And so we have, we can also have compression of the coronary arteries because of hypertrophy of this ventricle. And then this leads to low oxygen supply to the myocardial, to the myocardium itself, and therefore leading to myocardial ischemia. But we also have, because of the hypertrophy, we have increased myocardial needs, yeah, for oxygen, yeah. But because of this event here, because of the too much need and low supply, we end up with myocardial ischemia. Yeah? And we, on the other hand, we have incomplete emptying of the left atria because of the too much blood that is still within the left ventricle, and it will end up with pulmonary congestion and eventually right-sided failure. So that is a pathophysiology of aortic valve stenosis. Yeah. The clinical manifestations are almost the same. Yeah, we have fatigue, we have chest pain, exertional syncope, vertigo, things like posterior disease, pulmonary edema, things like signs of right-sided failure. So all these basically lead to clinical manifestations of aortic valve stenosis. Now with regurgitation, again, it might be as a result of a rheumatic fever, and other causes are Marfan's disease, which is basically a connective tissue condition, which is genetic. Yeah. Yeah. And what is the pathophysiology of this? So we have incomplete closure of the aortic valve, and leading to backward flow of blood from the left ventricle into the left ventricle, whereby we have we end up with left ventricular hypertrophy and dilatation because of the too much blood there. As a result, we can end up with what we refer to as left-sided failure because of the too much blood that is within the left ventricle, and as a result, we end up with a decreased cardiac output. On the other arm, we have increased, left atrial pressure. Remember, we are saying that because of the incomplete emptying of the ventricle, yeah, of the left ventricle. So it therefore means that blood will actually accumulate, or will subsequently accumulate in the left atria, yeah, leading to hypertrophy and the events that we have actually looked at earlier, eventually leading to right-sided failure. So this is the pathophysiology of this of aortic valve stenosis regurgitation. And these are some of the clinical manifestations or signs and symptoms. Things like, sometimes it is asymptomatic, especially on, apart from exertion, yeah? So when you do not exert, usually it is asymptomatic for years, and usually it is diagnosed on a wellness checkup, usually when they do echocardiogram, or even the ultrasound of the heart. Yeah. So we can also end up with a tachycardia, bounding pulses, the exertional dyspnea, chest pain, among others. Yeah. So now basically, when you know the pathophysiology of AV valves, and also the pathophysiology of semilunar valves, then you can know, you can basically tell what is actually going to happen, yeah, when there is a problem. So with tricuspid stenosis, it is almost the same as mitral stenosis, yeah. So please feel free to read about tricuspid stenosis, but we are saying usually it occurs together with aortic or mitral valve stenosis, and usually the problem is as a result of rheumatic heart disease, as we mentioned earlier. Now, the signs and symptoms that you should not forget are things of right-sided failure, yeah, as we highlighted earlier, yeah. So right-sided failure is basically associated with things like hepatomegaly, peripheral edema, neck engorgements, among others. Yeah. So again, tricuspid regurgitation is almost the same as mitral valve regurgitation. Yeah. And then pulmonic is almost the same as aortic. And then yeah, basically. So What are the diagnostic studies? Things like history taking, echocardiogram, electrocardiogram, cardiac catheterization, and then chest X-ray. These ones can help to basically pick the problem. But usually, we usually pick it as a result of echocardiogram, which we refer to as this ultrasound of the heart. Yeah. So what we usually do, especially if the problem is as a result of effective endocarditis, we usually give antibiotics, yeah, what we refer to as prophylactic antibiotics. Then we also give yeah, and also if it is rheumatic fever, you want to give you know, antibiotics, especially penicillins. These have been shown to be effective as far as you know, prophylactic antibiotics is concerned. Yeah. So, and if a patient is having signs of heart failure, then of course we looked at heart failure. Yeah. So they should be treated accordingly with either vasodilators, beta blockers, diuretics, or even a combination. Yeah? So you need to lower sodium and also anticoagulant therapy. All these can be used as far if the patient has a you know, that problem. We also have what we refer to as percutaneous transluminal balloon valvuloplasty. This basically splits open the fused commissure. So if you have if you have if you have if you have like valvular stenosis, yeah, then this procedure can be done. Yeah. So basically, that is it. It can be surgical management, valvuloplasty, or even annuloplasty. So with valvuloplasty, basically repair, yeah, of the cardiac valves themselves, and then with the annuloplasty is basically repair of the annulus. Now this is a little bit complex. You don't need to mind so much about it. Then a cordoplasty and then valvotomy. These ones are basically surgical procedures that are used in the management of these patients. Now, that marks the end of valvular diseases. Next, we want to talk about cardiomyopathies. And cardiomyopathy is basically a group of diseases of the myocardium associated with mechanical and or electrical dysfunction. Yeah. And usually exhibit inappropriate ventricular hypertrophy or even dilatation due to a number of causes, as we're going to see. Yeah. And cardiomyopathies either are confined to the heart or the or are part of the generalized you know, systemic disorders. And there are four types. We have dilated, hypertrophic, restrictive, and then what we refer to as arrhythmogenic, you know, cardiomyopathy. So with dilated, we basically have dilatation of the left ventricle, yeah, and so because of the dilatation of the left ventricle, we have a dysfunction of the systolic. Yeah, remember, if the ventricle overdilates, it basically means it will be unable to pump effectively blood. Yeah, and it is the most common cardiomyopathy. Causes are basically genetic. It can be as a result of myocarditis, alcohol, and other toxins, and also childbirth. Yeah, peripartum cardiomyopathy. And as you can see, this is a normal heart, and then this is a heart which has you know, dilatation of you know, of the ventricles, yeah, especially the left ventricle. Yeah. So they are stretched, and as a result, they enlarge. So it basically renders them ineffective as far as contraction to pump blood is concerned. Yeah. And that is another diagram of a dilated cardiomyopathy. Yeah. So basically, you have an enlarged heart. Because of enlargement and inadequacies in pumping blood, you usually have thrombi form. Yeah. And so dilatation of all chambers but ventricle, and then microscopically we have atrophic and hypertrophic myocardial fibers. Yeah. And then yeah, so basically that is dilated cardiomyopathy. And clinical features, basically it is highest in middle-aged. Symptoms are usually of gradual onset. We have things like pulmonary congestion, systemic congestion, low cardiac output, hypotension, because the heart is unable to pump effectively. Yeah. So that is a dilated heart. Yeah. So we also have hypertrophic cardiomyopathy. Hyper basically means too much. Yeah. So in other words, we have the heart muscle is hypertrophied. Yeah. And so basically it is too much hypertrophied that it hinders the functioning of the heart. Yeah. So with the hypertrophic, you have hypertrophy. So majority, it's the abnormality. So we have excessive thickening of the heart muscle, and so it usually begins during adolescence, and usually stops when growth has finished. And so we have the thickening is not symmetrical. Yeah. And usually the thickening is mostly it is this area which is affected, the septum. Yeah. And because when it is over hypertrophies, then it ends up obstructing the outlet. Yeah. It ends up obstructing these outlets, and as a result blood flow, especially of the aortic valve, is compromised. So as you can see, usually we have a symmetrical septal hypertrophy with obstruction of the outflow of blood from the heart might occur. The mitral valve touches the septum, blocking the the outflow. So in other words, if it overextends, this mitral valve touches here, and we see outflow of blood being blocked. So that is what we refer to as hypertrophic cardiomyopathy. So what is the pathophysiology? You have impaired diastolic feeding, yeah, because of the too much muscle, yeah. Then you also have reduced cardiac output and increase in pulmonary venous pressure, leading to exertional dyspnea and then pulmonary congestion, yeah. We also have diastolic dysfunction, impaired diastolic filling, leading to an increase in feeding pressure. You can have myocardial ischemia because of the too much compression of the coronary arteries, and then usually you have mitral gauge, mitral regurgitation, and arrhythmias. Yeah. So usually asymptomatic, and however, for symptomatic, it can be as a result of, it can lead to dyspnea, murmur, angina, fatigue, palpitations, among others. Now, we also have what we call or refer to as restrictive cardiomyopathy. Now, this one is as a result of, you have a rigid, ventricular wall, yeah? In other words, the heart is unable to effectively relax and contract because of the rigidity, yeah, of the wall, yeah. And because of the rigidity, it basically leads to impaired feeding. Yeah? So much less common than dilated or even hypertrophic, and it is characterized by a primary disease in the ventricular compliance, resulting in impaired ventricular feeding during diastole. Causes, it's basically idiopathic. However, associated other associated causes, we have radiation fibrosis, myelinosis, sarcoidosis. You have things like metastatic tumors, and then metabolic disposition diseases. So usually the ventricles are of normal size and the cavities are not dilated, but the muscle itself is rigid, yeah, and therefore it makes diastolic or ventricular feeding very hard. But also biatrial dilatation is common, and also we have a diffuse interstitial fibrosis is also common. We have symptoms of right and left ventricular failure. It can be diagnosed by Doppler, yeah, echo Doppler. So the other one that we basically do not have here is arrhythmogenic, this one here, and for it is as a result of inadequacies in the conduction system of the heart. Yeah, we shall do in cardiology nursing. We shall look at the conduction system of the heart, and with arrhythmogenic, the problem is with the conduction system of the heart. Yeah. So and therefore we have the heart not being able to function well. So basically that is that about concerning the cardiomyopathies and valvular heart diseases. Thank you so much. Please refer to the notes, read more in case you do not understand. Otherwise, that is that about the lecture. Thank you so much.